Thank you, Dr. Lippig. And so this morning we're going to provide a general overview of the radiobiological concepts and the models used in brachytherapy, and with a general discussion on how it might be useful in brachytherapy treatment planning and evaluation. I'd like to thank the program directors and the session chair to arrange this session at the beginning of treatment planning. So here are the learning objectives. As you know, brachytherapy are generally a little bit more complex than external beam radiation therapy. And lots of sources are used. Photon energies ranges from 20 to, say now, if cobalt-60 is going to be used in the HDR unit, to over 1 MeV. And decay half-lives range from days to over years. The treatment techniques used are just as varied. It ranges from temporary, continuous, low-dose rate irradiation that lasts about hours to days, to permanent LDR irradiation like we discussed yesterday, with exponentially decaying dose rate. And also, the multifraction HDR treatments or LDR treatments that are often combined with external beam radiation therapy. So the spatial and the temporal dose delivery patterns can be dramatically different between different techniques and different from the external beam radiotherapy. It is not uncommon to see dose or dose rate differ by a factor or more between techniques or within the target volume for the same technique. The clinical impact of this diverse spatial and temporal variations is very difficult to assess using the traditional dose-based matrix. As we discussed a little bit yesterday, because biological effects depends not only on the total dose, but also on how the dose is delivered, such as the dose rate or dose fractionation schemes used. So here's a plot from Eric Hall's textbook and showing the in vitro cell surviving curves of Chinese hamster cells irradiated at a different dose rate. It is clear when the same dose given at a different dose rate, the cell killing effect can be dramatically different. The effect of dose rate on clinical treatments has also been very well documented. Here is an example showing the influence of dose rate on local recurrence of breast cancer treatment using a combination of external beam and irradium boost. So now, when the dose rate of the irradium boost that is reduced by about a factor of 2, the local recurrence increased by more than a factor of 3. So the biological effect is fundamentally determined by the interaction between the radiation fields and the tissue being irradiated. This interaction can be affected by factors related to the treatment field or the factors of the tissue being irradiated. So the effectiveness of brachy treatment for a given patient would be a complex interplay between the factors involved. So radiobiology provides a scientific framework to study and to model the interplay between the dose delivery and the underlying cellular processes of the irradiated tissue. Now, we know the process leading from the initiation of a physical interaction to the biological response is very complex. It can usually be viewed as progressing through 3 phases. The physical phase is very short, and it is most well understood. It involves energy transfer from the radiation field to the biological system in the form of atomic excitations or ionization. The excited or ionized particles then react in the following chemical phases. And during this interaction, molecular damages in the form of chemical bond break result from either the direct interaction of the radiation or indirect radiation through such as free radicals formed by the interaction of the radiation field with other molecules in the cell, such as water. Now, it is generally accepted that DNA double-strand breaks represents the most significant lesion that would affect the fate of a living cell. Now, biological processes occurs over all over the place, ranges from seconds to years. As the damaged cells react to, as the cells react to the inflicted chemical damages, and some of the DNA damages, in fact, most of the simple DNA damages can be successfully repaired. Incorrectly repaired or irreparable cells eventually go through genetic mutations and mitotic cell death. Now, for tumor control, since the cells surviving irradiation will have a direct impact on tumor control, so cell survival has been often used as a surrogate for tumor control. Even though the radiation-induced cell killing is also detrimental to normal tissues, the effect on a particular organ function may also depend on tissue organization, basically the functional subunits, which can be nonlinear to cell kill. But nevertheless, radiation-induced cell kill has been generally considered to play a central role that affects the biological response of the irradiated tissue. So there are a number of models proposed to describe or predicting the cell survival curves. And some sophisticated models include a modeling of the kinetics of cell damage induction and repair. Among these, the so-called okay, so I think the slides took off away. Okay, actually it's there. So, so the linear quadratic model that was listed there, and it used to be considered a good curve-fitting model. And because of its simplicity, it has been used most often in clinical studies. In addition to be able to provide a good curve fitting, and one can actually attribute a plausible mechanistic interpretation to the LQ model. This quantity showing here, in general, is considered as an expected number of lethal lesions produced per cell. And now it is generally accepted that the alpha term, the alpha D, represents the lethal lesions from one-track damages that resulted from irreparable lethal misrepair of double-strand breaks or intra-track exchange-type chromosome aberrations. The beta term represents two-track lethal damages resulted from inter-track exchange-type chromosome aberrations formed through lethal binary misrepair of two separate double-strand breaks. And the relative importance of these two modes of damages are reflected by the coefficients of alpha and beta. The ratio of alpha beta, which equals to the dose where these two modes produce the same amount of damage, and it's an important parameter to measure the relative importance of these two modes damage in a given cell or given tissue. And it is also a very useful clinical descriptor because it measures cells' sensitivity to changing those fractionations. Now, the one-track damages, you cannot do anything about it. But at the two-track damages, if it's occurred at the two different times, then there is a chance one of the damages can be repaired, which may prevent a lethal, the fate of a cell going to a mitotic death. So in order to model that, a parameter can be introduced, which involves the repair capacity of the cell and at the time of the dose irradiation. And this factor is normally called dose projection factor because it relates to the finite time that they used in delivery dose, and then the repair occurred during that time. If the repair can be assumed to follow a mono-exponential kinetics, then this dose projection factor can be written in this most general form where it relates the physical dose, instantaneous dose rate, and the probability of damage repair. So any type of temporal dose delivery patterns, as long as it can be represented in this formula, in theory, you can calculate. So this repair time constant is inversely proportional to so-called repair half-time. For mammalian cells, it ranges from minutes up to 10 hours. So as we showed yesterday, this dose projection factor has been worked out for a number of brachytherapy situations. So this shows a situation where we deliver the dose in a uniform dose rate for a finite time. And when we deliver it in fractionated fashion, and if the dose for each fraction, the delivery time is not instantaneous, then this dose projection factor appears like this. So we're going to talk about this in Wednesday's talk, and then this in Tuesday's talk for the HDR brachytherapy. This is for GYN brachytherapy biology. And we also showed this yesterday for LDR prostate brachytherapy. So in fact, the dose projection factor can also be worked out in the general closed form for post-brachytherapy delivery. Now, since post-brachytherapy delivery is trying to design a treatment to simulate the same effect of LDR brachytherapy, so one could argue in order to optimize or design a good sequence of PDR, consideration of radiobiology is most critical, most important. So for the time, for the sake of the time, we have not included that in the talk, but there is a description in the handout. Now, other time-dependent processes can also be included into the LQ formalism. The easiest one is the tumor repopulation. So with these two additions here, the generalized form of LQ model, you can describe the effect of cell repair, damage repair, and the cellular proliferation during the dose delivery. Now, both the effect of these two are dependent on the time of the dose delivery. Since the repair half-time for damage repair lasts on the scale of hours, and the impact of damage repair will start to show up whenever the treatment delivery lasts more than several minutes or hours into hours. Similarly, because the tumor cellular doubling occurs on the time scale on the days, so this would be the impact if the treatment duration goes beyond the days or into months. So both of these are will negatively impact on the treatment effectiveness. If you look at this, this represents only 2 of the 4 R's in classical radiobiology. The other 2 R's include reoxygenation and the cell cycle redistribution. Now, those 2 are not as easy to incorporate into the LQ formalism, although good progress has been made by Mariana Guerrera and David Carson, recently who published a paper in the Medical Physics, and looking into incorporating oxygen cell reoxygenation into the LQ formalism. So obviously, both of those R's are advantageous in terms of increase the treatment effectiveness. So we also mentioned yesterday a little bit, so I'm not going to spend too much time here. Most of the studies can be done within the LQ formalism, but for practical purposes, some models are easier to use in clinical applications, one of which is the biologically effective dose. And same treatment with the same biologically effective dose will produce the same cell kill, therefore same biological effects. And this is the simplest of one, which you can, when the repair and the repopulation are neglected. In this case, one can use just the single alpha-beta ratio, try to relate a particular dose fractionation scheme to the expected biological response. And we should be mentioning that the BED, even though it has a dose in its name, and it shares the same unit of dose, it is not a physical dose. And it should not be confused or with the so-called biologically equivalent dose. So that's why this is called biologically effective dose. So one of the most often used biologically equivalent dose is the EQT2. Now, EQT2 is fundamentally the same as LQ, except it takes the assumption that the cell survival can be used as a surrogate of biological response one step further. So if we are concerned about one treatment, so we can calculate the BED like this. And we also know the BED for a treatment delivered in 2 Gray fractions can be expressed like that. So in theory, you can always find an equivalent total dose when it delivered in 2 Gray fractions will produce the biologically effective dose same to the treatment that you are starting with. So EQT2 is nothing but a BED divided by this factor that is related to the BED of those delivered in 2 Gray fractions. So strictly speaking, in order for EQT2 to apply theoretically correct, the treatment time between the 2 schemes has to be the same, or you can assume there is no cell proliferation. This is a simple form of EQT2, which we often see in the protocols. Unlike BED, EQT2 is directly related to dose. So it gives an intuitive feeling about what the treatment is compared to the experience we gain from the delivering external beam in 2 Gray fractions. So for this reason, ICRU and Jack Astral has recommended to use EQT2 for bioeffect calculation and for reporting. And in fact, most of the recommendations for GYN from the American brachytherapy are actually expressed using the EQT2 specifically as a criteria. So brachytherapy is intrinsically inhomogeneous. And the formalisms we talked about before applies for uniform dose distribution. But you can actually calculate an effective BED for a homogeneous distribution by subdividing the volume into a such level that each voxels can be considered receiving a uniform dose. The effective BED calculated is preferentially weighted by the low dose. So if you want to evaluate the biological significance of cold or hot spot in the system relative to the underlying anatomy, you can also calculate the so-called 3D BED distribution and any other things such as BED volume histogram. And so obviously, I'm running I have 1 minute left, so I'm going to have several slides, but I'm going to go through this very quick. So far, we talked about using cell survival as a surrogate. Ideally, you want to relate this directly to, say, tumor control or normal tissue communication. With the cell survival, you can actually calculate TCP if you assume the radiation-induced cell kill follows a Poisson statistics, and also you know the initial tumor burden. So you can do this calculation and then try to relate it to the observed local control from the actual clinical treatment, but just be aware of the underlying assumptions. So how can we use this in brachytherapy? Currently, because of the simplicity of the model and the uncertainties in the parameters, it cannot be used for absolute prediction of a treatment response. Most of the applications are used for relative comparison of different treatment techniques. On the upper level, on the more general level, you can consider the application in sort of two groups. In one group, we can use it to compare relative effectiveness of a given treatment on different biological systems. So in this case, the model parameters are fixed. Dose delivery are the same, and the model parameters you can vary. So you compare the treatment technique on different biological systems, such as fast, slow-growing tumors. Or you can compare the relative effectiveness of different treatment techniques on a given biological system by fixing the model parameters. Oftentimes, these two are done together, like what we showed yesterday. We can compare the relative effectiveness of cesium, iodine, palladium on prostate, and then you can look at that, how the treatment is susceptible if the patient have a different model parameters than the general parameters recommended. So in terms of treatment planning, so we can use radiobiological models for treatment technique selection, for treatment plan optimization and evaluation. And we can also use it for sensitivity analysis of a resulting plan with respect to potential variations in dose delivery and in patient radiosensitivity, quantifying the impact of dose heterogeneity and do proper assessment of the combined effect when it combines with the external beam. So the next 4 slides, we will talk about again in the Wednesday's talk on GYN. So I'm going to skip through and then jump into my conclusion slides. So as we see a little bit, the radiobiological models are very useful to give us a sense of how things goes. However, rigorous validation of radiobiological models for brachytherapy especially is still lacking. Because of the simplicity of the model and because of the uncertainties in the model parameter, so we have to be always careful and cautious whenever we use such models. Well-controlled, well-designed clinical trials remains the gold standard whenever we try to introduce or develop a new technique. And with that, I'm going to end. Thank you very much.